Good evening, everybody. My name is Dermot Ferguson. I'm the chair of the National Back Pain and Clinical Network. I'd like to welcome you all this evening for the launch of the framework for early recognition of Cauda-Equina syndrome for primary care clinicians. This framework has taken some time to get together and has been the brainchild of lots and lots of people have got together and worked in partnership to develop this framework. It is a starting point, and we'd like to share how we've got with everybody. Now, the plan for this evening is I'll just give a quick introduction as you see me now. I'm going to pass over to my colleagues, Michelle Angus, and the sessions is being moderated by Jim Greenwood and Susie McAvoy. This session has been taken some time to get together, mainly because we were going to release the framework at Britspine. Britspine is a national spinal conference where all the leading spinal societies get together, and we thought that would be an ideal place. But obviously events have overtaken us, and we thought that actually this framework needs to get out there because it's an important and critical bit of work that needs to be shared. I'd like to thank lots and lots of people, but I think what we should do is really get going. I'm going to pass over to Michelle now, and she will give the outline of the evening. And then I'll come back together. The main thing with this is an interactive session. Any questions you have, please put them on the question answer. The chat room is open, but hope you enjoy the evening, and we can't wait to get starting and share this framework with you.
Thanks, Dermot. Thank you, everybody, for joining us. We're going to start the evening with a live poll just to find out a little bit about you and who's with us tonight. So if we can put question 1 up, Henry. So we'd like to know who you are, who have we got in the room tonight? Have we got advanced practice physios or chiropractors, osteopaths? Who's with us? If you can vote for us, and then we'll have a little look at who we've got. Brilliant. So we're mainly physios and advanced practice physios out there with us tonight. So welcome. It's great to have you on board with us. Next question we're going to ask you is where you work. So we're interested to know, are you primary care, secondary care? Are you in district general hospitals, interface services, A&E? Where do you classify where you work at the minute? Brilliant. So most people are primary care and in interface services with a couple in specialist spinal services. So that's great. Great mix there of everybody. And then the final question, just to see again who's out there. What's your local pathway? Do you send people back to their GP? Do you refer directly to tertiary spinal services or secondary care orthopedic services? Or do you send them to A&E? What's the local pathway where you live at the present time? Okay, so most people send to A&E, but there's a few other pathways out there, and hopefully we'll cover these things as we go ahead tonight. So each of the speakers is going to do a short presentation. We've purposely kept the presentations relatively short to give more time for question and answers, because we feel that with this framework, we want to answer the questions that you've got out there. We want to try and cover everything that you want us to cover. So it's your evening to be guided by what you give us. There is a chat function on Zoom, so you can chat amongst each other. For those of us who are on Zoom. On YouTube, you're welcome to tweet us. You can using the National Back Pain Clinical Network Twitter, and engage with each other as best you can. As you all know, that we get more out of peer support and peer review, and we want you to be as involved as you can be. The whole time is going to be 90 minutes, but we will have as long for questions as we can at the end, depending on how long we take with each presentation. And the framework hopefully has been sent out to everybody by our wonderful admin support, Henry, who we couldn't do without. And it's available, will be embargoed till Friday, but then it'll be available for everybody from Friday on this website. We've got a brilliant group of speakers here tonight, and we'll introduce each one as we go through, who've all got different areas of expertise and different things to share with you. So hopefully there's a lot to be gained, and a lot to be gained from the Q&A, which we'll do at the end, and Susie will and Jim will moderate that for us. Lastly, it'd be great if you can fill in your feedback form at the end of the meeting, which will be sent out to you. The more feedback we can get, the more we can put these things on and make them better for you, and we can get more out of it. And lastly, thank you for attending. Thanks for giving up a Thursday evening to be with us tonight. We're all excited about it, and we hope you are too. So firstly, can I hand over to Chris Mercer? Chris is a consultant physiotherapist, who I'm sure everybody out there knows, as most people are physios, at the Western Sussex Hospital. Chris is also working with NHS England as part of the Change Challenge project, and he's the chair of the consultant physio group for the CSP. So over to you, Chris.
Thanks very much, Michelle, and thanks for having me this evening, and good evening, everyone. So I've got a few minutes to talk about a brief overview of some of the literature. But I thought I'd start with the challenges, really, and I think the challenges we have with cord requiner were summed up quite nicely by a Nick Todd paper about 3 years ago, and he described the red flags that we've traditionally been following as white flags of surrender, and I think that's definitely the case traditionally in the red flags we've been given for cord requiner in terms of urinary retention, bladder and bowel dysfunction, or bladder and bowel incontinence. You know, it's too late by then, so we have to do better. And I think that was a fairly seminal paper, really, just and a sensible way to think about things. So in terms of our diagnosis of cord requiner, there's been a lot of work done in lots of areas. I'm going to mention this first one on the top left-hand corner, just because myself and Sue were involved with this, but this was a piece of work led by Laura Finucane on behalf of IFOMT. It's an international piece of work, and we'd come together to try and help out with red flags, to try and get some international consensus around 4 serious pathologies, one of which was cord requiner syndrome. And we'd come together because of the paucity of hard evidence. And I think that's reflected in some of these other studies on the page here as well. If you look at the UKES, the Understanding Cord Requiner Syndrome study, this was a protocol for this prospective study that was looking at referrals into tertiary spinal centres because there was a real paucity of data. The study on the bottom right, the Corso et al. Paper, is really a sweep of smallish studies looking at signs and symptoms of cord requiner. And one of the things that is common amongst all of the cord requiner studies, really, particularly with case-based studies, is the small numbers. And we've struggled with that over the years to get real definitive diagnostic criteria. So this paper up on the right-hand side, the KESCOS study, is a Canadian study that tried to come up with some core features of cord requiner syndrome. If you can just go on to the next slide, thank you. And this is what they've come up with. And I think one of the things that struck me with this paper was really there are very few kind of physical tests in here. A lot of if you look at where the weight of the evidence here is, and this isn't new, the weight of the evidence here is around subjective. There's sensation testing, which we'll talk about later, and Elaine will touch on. But there are a huge number of quality of life issues there that are strong features. And I think this is something we probably haven't recognised as well as we might have in the past. And I think these will be increasingly important in helping us to establish those patients with true cord requiner, because we know that our strike rate is poor. So go on to the next slide, please, Michelle. We know our strike rate's poor because we have lots of people with negative scans. The percentage of people with positive scans that correlate to their positive clinical findings is very small. Somewhere between 15 and 19% of patients, depending on their studies, will have a correlation between their clinical findings and their MRI scans and go on to have surgery, which means that around 80 to 85% of patients end up not having surgery, even though they present with clear signs and symptoms of cord equina, be that back and leg symptoms, plus or minus urinary symptoms, sexual dysfunction, all of those things that we would recognise as being potential cord equina related symptoms, but they're not, and that's a challenge for us. So this Gibson paper here talking about scan negative cord equina syndrome. They've done a pilot study that looked at some of the features of those patients with scan negative cord equina presentation and found significant array of psychosocial issues with those patients. So there's some question around whether it is a functional neurological disorder, whether it's a psychosocial issue along with a chronic, almost like a chronic pain presentation. And I think that's an area that's going to develop and for us to look into. And the danger with this is that we don't want to assign patients to that category without doing due diligence. So it doesn't give us an easy diagnosis. It doesn't give us an easy way out. It might offer an explanation for why we only get a small percentage positive correlation between clinical presentation and scan findings, but it doesn't make it any easier. You're still going to have to be very, very brave not to scan that patient who presents with those signs and symptoms. So there's a lot more work to be done before we start to stratify these patients, I think, but it's an area to explore. The compressive study, the SAVA study here, was looking at a different type of investigation and different type of mechanism for those patients with true cord equina, and suggests that the damage is done very quickly, and the damage may well be related to the pressure within the spinal canal. And yeah, you'd think that pressure would need to be very high, but anything above mean systolic blood pressure has been shown to cause damage to the spinal roots. And if that pressure's on there for more than an hour, then that damage may be irreversible. So again, we've got a very, very small window to change the outcome in these patients. But clearly we can't investigate these patients with pressure tests at the moment, but that may be somewhere to go forward to. Next slide, please. In terms of our management of these patients, clearly we're trying to get these patients through to MRI scan, through to spinal surgeons as quickly as possible. The ENTICE study looked to see whether we were actually doing that and followed a huge number of patients. So 4,500 patients were involved in this study. Follow these patients through on their journey from diagnosis to a surgical decision. The surprising finding and kind of disappointing finding is that 60% of these patients arrived in front of a surgeon without having had a scan, and clearly that's not ideal, and that's not to point the finger at the clinicians who referred them, given that 63% of these referrals were done out of hours, so that may well reflect the fact that these clinicians had no access to MRI scan. So clearly that's not ideal, because again, there are a very small percentage of these patients went on to have surgery, so it's about 16%. So I think that's a challenge for us. We know that timing of surgery is key. Cleaver McFarlane told us that years ago, and this Hogan study tells us that that's still the case. So no shit Sherlock, really, and that's not that surprising. We know that, and it still holds true. But these guys looked at a huge number of patients. I think it was 20-odd thousand patients. 21,000 patients they looked at over a 4-year period, controlled their records, and found that those patients who had surgery within 1 day had much better outcomes. So again, our window of opportunity is very small. This timely article by Hussain et al., they'd looked at 250 cases, found similar findings to the entire study, that actually these patients were poorly managed. There was a small number that got through to having surgery, and many of these patients arrived without scans, and suggested that there was a need for a national pathway, which is a blooming good job, because that's what we're here to present to you, and I think it's very timely. So I think I'd summarise probably and say, look, there's still an emerging field. We know there are a lot of papers on cord requiner. The vast majority of these papers are small studies, not high quality studies. So there is a real need for high quality studies. I know Michelle's involved in a study that hopefully is going to be funded and starting a prospective study. And those are the sort of trials we need to really get good data. And there are some other trials coming up that I'm aware of and may be involved in. So I think it's an exciting time, but I think we're still in an emerging field as far as the evidence goes. The good thing is that most of the evidence comes out of the UK. So the UK is leading the field in the world on cord requiner research. So I think this pathway is a step in the right direction, not just for the UK, but for the world in managing these problems. Thanks.
Thanks very much, Chris. Susie, Jim, have we got any questions for Chris?
Susie? Sorry, I had muted myself. We haven't got any questions on the Q&A function. So if anyone does have any questions they want to ask the panelists, please do put them in the Q&A and we will get them asked as best we can. So without a question, I might pose a question to Chris, although I think you did touch on it. You talked a bit about the Gibson paper. Why do you think there's a relationship between lots of positive signs and symptoms and then negative scans?
I think because it's not a black and white condition. I think there are so many other comorbidities that can masquerade as cord requiner. You know, if we talk about simple common conditions like urinary incontinence, urinary dysfunction, either in male or female, you know, the incidence in urinary incontinence in over 40s is 40 to 60%. In men over 40, erectile dysfunction in 40%. Just for starters, and then we've got some physical and pathological disease processes that can mimic some of the signs and symptoms after childbirth. Something like 30% of women have loss of perineal sensation and may not realise it because there's so much else going on. And about 30% have perineal tears, third degree, so potential for significant damage. We've got a whole host of neurological conditions that can masquerade. So we may need to look further up the spine, things like MS, transverse myelitis, etc. And the medication we give people. And then we've got some of the psychosocial factors as well. So I think it's a much more complex condition than we give it credit for, really. I think we've been a little bit stuck in a pathoanatomical descriptor of these signs and symptoms, and I think we just need to be aware and keep our differential diagnosis hats on and keep it broad before we narrow in. So I think there is something around that, really.
And just following up from that, so the patient's had a scan and it's been negative.
Yep.
What do you think we should then do with this patient that's presenting with symptoms? Whose responsibility is it, and how do we help this patient?
Yeah, I think that's always sometimes it's a bit of a, oh God, what is it? And sometimes it's a, oh, thank God for that, it's not cord requiner. So I think a combination of the two is probably a sensible approach. Yeah, my initial thing is, well, thank goodness it's not cord requiner, because I know this is a life-changing condition for patients, and actually you wouldn't wish it on anyone. But then you can't wash your hands of the patient. You've still got a patient with the same signs and symptoms. So part of your duty of care to that patient is to either continue with further investigations. So you may want to consider scanning up or scanning out into the pelvis to look for other causes, or you might consider referring on. But what you can't do is just leave that patient hanging around. If patients are presenting with these significant symptoms, what they need is an explanation. So if your explanation isn't that it's cord requiner, if you've gone up and it's not further up the neuroaxis or further into the pelvis, then you'd need to look elsewhere. and you might then need to discuss with urology or gynecology colleagues, or renal colleagues, or bowel colleagues, or whichever speciality might fit the symptoms better.
Okay, I've just got one final question for you, Chris. Sorry, and this just came up from Jo Hutchings, and she was asking, what's the definition of a negative scan?
A negative scan is not showing caudal guinar compression. So it might show some nerve root compression. It might show degenerative changes. It might show pars defect, but it's not showing caudal guinar compression. So your question on your scan, based on the patient presentation, would be, query, does this patient have caudal guinar compression? And the radiological report will be, no, this patient doesn't have caudal guinar compression. They may have a host of other things, but if they don't have caudal guinar compression, then you've got a negative correlation between your clinical examination and the scan findings.
My understanding is it has to be something like 50% reduction in diameter for a radiologist to report it.
The radiologist, it depends on the radiologist, but the radiologist would say 50% maybe severe stenosis, or caudal guinar compression, depending on where the level is. Spinal surgeons, as Patrick was saying last night, was around 75%, or a loss of complete loss of CSF on the axial views around the caudal guinar nerve roots.
Thank you.
Thanks very much, Chris.
Thank you.
Chris will be on the panel at the end for any more questions, so do keep asking them, please, on the Q&A panel. So up next is the bit you've all been waiting for, is Elaine Buchanan, who's a consultant physiotherapist in Oxford and also president-elect of the Society of Back Pain Research. And Elaine is also the editor of the National Back and Radicular Pain Pathway. So Elaine's going to talk us through the framework, and hopefully this is the bit everybody's been excited about.
Hello, everybody. An important part of the NHS England Improving Spinal Care project was the development of the National Back and Radicular Pain Pathway, and that was the beginning of all of this. Following on from that, the National Back Pain Pathway Clinical Network was founded in 2017. And the whole purpose of the network is to promote the implementation and advancement of the National Back and Radicular Pain Pathway. The National Back Pain Clinical Network has always been closely associated with the UK Spine Societies Board and is now one of the constituent societies. BAS have certainly led the way with the development of the standards of care for investigation and management of caudal guinar syndrome in secondary care. At Brit Spine 2018, the National Back Pain Pathway Clinical Network contributed to a really successful caudal guinar session, which was more than a full house. People were standing all over the room. And then in 2019, Connect Health published their white paper on caudal guinar syndrome, and really because of the muddy waters that there were related to bilateral leg pain as a red flag for caudal guinar syndrome. So in response to all of these things that have been happening, the network set up a working group and had their first meeting in June of 2019. So it's taken quite a long time for this framework to actually be developed. We've had lots of emails and there's been many, many drafts. We've sought feedback from everywhere that we possibly can. Sorry, next slide, my fault. We're very grateful to all who have contributed to what is a truly multi-professional document, which we hope will enforce earlier identification and emergency referral for people with symptoms and signs of caudal guinar syndrome. It was clear that there was a growing unmet need to have guidance for the management of suspected caudal guinar syndrome in primary care, because really there was nothing out there before. Next slide, please. Tonight, the National Back Pain Clinical Network is proud to launch their framework for early recognition of caudal guinar syndrome. I very much hope that you have all received a copy and had some time to digest it. The framework can be found at the link at the top of the page here, but if you go on to the, I think as they said, it goes live on Friday. But if you go onto the UK Spine Societies board, look for the National Back Pain Clinical Network and you'll be able to find the link from there. The framework is for primary care and MSK interface services to use to shape the local and regional policies, procedures and pathways for suspected cauda equina syndrome. It provides guidance on the clinical identification of cauda equina syndrome best that we can, a bit of guidance around other differential diagnosis to think about because signs and symptoms can be coming from other causes, how to safety net and the emergency referral where signs and symptoms indicate a higher risk of acute cauda equina syndrome. There's an emphasis on communication, documentation, and the time-sensitive nature which requires emergency escalation of that patient. Next slide, please. We got a lot of feedback and we divided that into themes. These are the general themes that were coming up. And I'm sure you'll be no surprise to any of you to hear the two strongest themes were anal sphincter examination and bilateral leg pain. Next slide, please. The problem is that on its own, anal tone testing is not a good test. The evidence is high risk of bias due to low quality. All of these studies are done in secondary and tertiary care. We really don't have evidence for their usefulness in a primary care setting. There's also no control of the testing procedure or the inter-tester reliability. So we don't really know how well these tests were done, and they're generally retrospective studies. All of the studies generally report on anal tone, but yet people say that the more useful test is actually that of a voluntary anal contraction. And we don't really have studies on that. We know that in a hospital setting, anal tone is better at ruling out cauda equina syndrome than it is at ruling it in. And there's always going to be a lot of a high rate of false negatives. There's we don't know enough about the clinical utility yet of combining flags, but certainly we think that's something that shows promise. From a primary care perspective, the prevalence of cauda equina syndrome in primary care is very, very low, around the region of 0.04%. Although anal tone testing is not difficult, I mean, anyone who knows how to test a muscle can test anal tone. The problem is that people might never have done it before. They might not feel confident to do it. And in primary care, there's often an issue around lone working clinicians, and there is no chaperone available. The majority of clinicians do not have specifically spinal experience, and that limits their interpretation when they do the test, like, is this important? Is it not important? What am I going to do with those results? There are varied views about the usefulness of anal tone testing in a hospital setting, but that is out with the scope of the National Back Pain Clinical Networks framework. Next slide, please. The thing with bilateral leg pain is it is not well defined. When Connect Health brought out their white paper, there was a big concern about the tsunami that was going to cause, because the experience of the committee members that we have in our network is that there are many patients presenting to primary care with bilateral leg pain. You can't send everyone to A&E. It's just not practical for A&E. Further, many people with severe unilateral sciatica also have pain in the opposite legs for lots of associated reasons, but not because of nerve root compression on the opposite side. Again, the evidence is very weak and there's an extremely high risk of bias here. In isolation, it's simply not a good test. I'm sure you've all read the study by Dion, who estimated that the pooled specificity is around 0.66 and the sensitivity is about 0.43. Again, high risk of bias due to low quality. All the studies are done in secondary and tertiary care, and we do not know the prevalence of true bilateral radicular pain in primary care. So essentially, this is a test of moderate specificity, but very poor sensitivity. And it's not even as good diagnostic value than anal tone is. We did emphasize that it is more helpful to identify bilateral pain in a radicular pattern, and then agreed on a pathway for 3 clinical scenarios, and you'll find further details of that on the framework. Next slide, please. The National Back Pain Clinical Network experience of developing this framework has been really, really positive. We started with a small working group, and things have really snowballed from there. The support that we've had from the UK Spine Societies Board and BAS have been absolutely outstanding. So the next steps for us is really to reflect on how much you can do when you work collaboratively with other societies. And our next steps are really to try and join up the cord equina syndrome pathways across the whole system, rather than there being one for primary care and one for secondary care. We need to think about what happens in A&E departments, what's happening in GP practices, and have an end-to-end pathway like we do have for the National Back and Radicular Pain Pathway. It would be great to see NICE endorsing this, and we did have a speaker from NICE last night, and it sounds like that is certainly going to go ahead. In England, we're looking for NHS England sign-off, and we should be able to get that done through the clinical reference groups. Obviously, we would like it signed off by the health authorities in Scotland, Wales and Northern Ireland. We need to work with the Royal College of Emergency Medicine to try and get things aligned there. And we very much need to involve patient groups to hear the voice of the people who suffer. Next slide, please. We very much hope that the implementation of this framework will contribute to reducing the numbers of people who live with symptoms of persisting cord equina syndrome. We have to always remember that this is a condition that has a devastating effect on personal and social lives. It's also sad because many of these people who develop this are young or middle-aged people who were in work prior to onset, and the consequences really dramatically change their quality of life. Thank you.
Thank you very much, Elaine. Jim,
Thanks,
Susie,
Elaine.
we've got questions for Elaine.
Thanks, Elaine. That was marvellous. I wonder if you can tell us why the framework still wants us to objectively test perianal sensation, but does not want us to test anal tone.
So essentially, we have the same situation here where the quality of evidence, it doesn't matter what sign and symptom you're looking at, the quality of evidence is poor for all of them. From what we know, saddle sensation actually has the best diagnostic value of all of the cord equina red flags that we have. And the Dion study reports a likelihood ratio of around 2 for positiveness. But even that falls out of the reach of the threshold for clinical relevance. So it might be the best test, but it's still got a lot of limitations. The consensus of those who see and operate on cord equina syndrome most often is that altered saddle sensation is also an important early sign, where the anal tone testing is something that you see as a late sign. Anal tone changes are something that happens as a late sign, and also have much lower sensitivity and specificity, so they're clinically less useful. All primary care clinicians have got training and competency to objectively test dermatomes. It's not difficult to also test the saddle sensation as well. It's the same thing, but not all have got the competency to objectively test and interpret the findings of anal sphincter dysfunction. Objectively, altered saddle sensation would add to the indications to refer someone to an emergency medical service, where we don't think that anal tone does.
Thanks, Elaine. That's really clear.
Thank you. Next up, we have Jonathan Field, who is the chair of the specialist faculties of the Royal College of Chiropractors. And Jonathan's going to talk to us about the view from small independent providers on cord equina syndrome in this framework.
sorry, muted. Have the next slide, please. Independent providers are likely to see patients presenting with symptoms of cauda equina, just like the primary care services in the NHS and secondary care, and they're very much in a position to help identify these patients and to move them into a pathway where their symptoms can be managed to avoid some of the devastating long-term consequences of the disease. And also they need to be very aware of the medico-legal consequences, because there's lots of lawyers and barristers out there who are very keen to chase any sniff of a missed opportunity to pick up and diagnose cauda equina. It is a challenge to identify cauda equina syndrome in its early stages. It doesn't present as a black and white condition, I'm afraid. The next slide, please. The steps that an independent provider would need to take are the same as any other provider, but of course they haven't usually got the resources around them of additional staff, nursing staff and hospital facilities. The initial identification of cauda equina syndrome is done through history, looking for changes in bowel and bladder symptoms. And what we're looking particularly for is a loss of sensation or a loss of sphincter control to either bowel or bladder. Symptoms, progressive symptoms in the leg, particularly neurological ones. When doing a history, what's vitally important is we actually look for change. So if someone presents with stable, long-lasting change of bowel and bladder symptoms, that's not a sign for emergency referral. But if they had recent onset changes, then that is much more significant for us. With examination, patients should always be screened for neurology to the legs, upper and lower motor neuron symptoms. And as we've been hearing, perianal and perineal sensation testing should be done. The pathway calls, or the framework calls, that if people aren't going to do these tests, to actually document quite clearly why they didn't do it. What's their rationale for not doing it? Was there lack of chaperone, lack of confidence, lack of patient consent? The pathway calls for us to contact a colleague to discuss cases where we're not clear what the referral should be. And I think it's probably going to be a good idea for independent providers to think in advance who that colleague is likely to be, because if this presents to you in a clinic, there can be quite a lot going on, and in the heat of the moment you might not know who to contact. So actually having that pre-prepared can be very useful. The next slide, please. In order to make the referral, we may or may not have access to the same pathways as within the NHS. I know Steve Vogel is going to talk more about independent referral pathways in a moment. It is very, very important that independent providers safety net their patients. So if you're not going to make a referral then and there, you actually alert the patient what to watch out for and what steps to take if symptoms that are cause for concern arise. We need to have very good documentation in our notes of all stages of the clinical encounter. That's both what the patient tells us, what we ask the patient at the examination, and any advice that we've given. And if we suspect a patient may have cauda equina and we make a referral, if the cauda equina isn't confirmed, we need to then make a decision about what we're going to do with that patient. Are they an appropriate patient for our care, potentially in physical therapy, or do they need referring on elsewhere to manage their symptoms? Next slide, please.
Okay.
Thanks very much, Jonathan. Susie, have we got questions for Jonathan?
Yeah, just a quick question here. There's a question here: do I have to carry out sensation testing of intimate areas if I don't feel comfortable doing this?
So the framework does call for testing of saddle numbness, and as we've just heard from Sue, it is one of the most sensitive and specific tests that we've got. If you're really not comfortable doing it for whatever reason, then you need to be documenting very clearly in your notes why you haven't done it. When we're talking about testing here, we're talking about perianal sensation testing and maybe perineal and around the thighs. We're not necessarily talking about, certainly not in community care, talking about testing of genital numbness.
Okay, thank you very much.
Thank you, Jonathan. Thank you, Susie. Okay, next up we have Dr. Sue Greene, OBE, who is a consultant physiotherapist at Bolton Foundation Trust and a clinical fellow at Manchester Metropolitan University. Sue's also the clinical lead for the FCP project within Bolton, and I'm sure, again, as physios, most of you are well aware of Sue and her work.
Thanks, Michelle. Can I have the first slide? So I've been asked to talk about the pathway and the pathway locally. And what's important about our framework is that it's a springboard for local discussion. It's a great opportunity to get this pathway right, to avoid life-changing outcomes for these patients, but also efficient use of local services. And some things to consider. Don't work in silos at developing your pathway. Get involved with any stakeholders that you might be able to work with. So as a lone worker, you might be referring directly to A&E, but you might be lucky enough to have access directly to radiology, to the spinal team, which is great, particularly if you work in an interface service. Working with these departments are key in getting your pathway streamlined and timely. But don't forget the front door to your service. Over the years that I've been working with this condition, I've seen some issues related to maybe a kindly receptionist or administrator of a service leaving a referral for somebody to see the next morning or that night. We want none of these referrals to be left on an answer phone. So involve your administrators and reception team in knowing exactly what your service offers and what they should do should any of these referrals come to them. They're obviously not clinical, but they are sometimes the front door into your service. Now, it's really important for these emergency conditions that you consider your capacity and your service and across all boundaries. So don't forget, looking at the framework and guidelines, we need to triage the patient, consult, so we need to do the subjective and objective examination, organise an emergency MRI, maybe a bladder scan. And who's going to review those? Who's got the responsibility of following that image up in a timely manner? Parceling all of that clinical decision together, which is how we get to diagnose Cauchy-Quiner syndrome and get all that to the surgical team maybe the same day. This can work really well if you work together, but you have to have that capacity. Don't forget you need flexibility. These are urgent conditions. Have you got the capacity in your service to deal with that daily variation? And sometimes peaks in the week. Commonly Friday afternoon is known, and I know that lots of you listening to this today will be nodding to that Friday afternoon disaster. So this framework is a great opportunity to use as a springboard to discuss how you can improve what you've got and how you can make it better. Something that I love on our framework is the debriefing if the case is positive. Now, this is so important because your pathway isn't a static document. If you get a positive case, reflect on what went well, what could have gone better. If you change your pathway, have a version control on it, the date at which it was changed. So if you need to look back on your pathway in 3 or 4 years to come, you know exactly which pathway you were dealing with. And we're all here because we're really keen to help the patient, to avoid unnecessary harm. But what about us as clinicians? I think Dermot started yesterday evening by saying these can be so stressful, particularly in a primary care setting when you've not got a surgeon, spinal surgeon on site. These are the people you can lose sleep about. We need to look after each other, and these debriefing sessions can look after our clinicians too. Next slide, please. So Jonathan talks a bit about safety netting. I'm not going to go into this too much, but working with our patients as partners helps us to get the patient in the early stages. If they understand what's important to us, what to look out for, what to do if they appear, and exactly when and where to go, that is so important. We know from the qualitative work that I led some years ago that patients didn't understand the safety netting advice that they were given. And so clear communication in patient language is important. This needs to be given both verbally, documented, and give the patient something to take away. Importantly, explain to the patient the consequences of not acting on these symptoms in the timely manner that you describe to them. They might not want to bother a clinician. And we know from the qualitative studies we've done interviewing these patients that they equate severity of pain with severity of the condition. So saddle numbness to them sometimes is a suggestion they're getting better. Hesitancy of passing urine isn't necessarily a problem to them in the context of significant agonising pain. Think about the literature you're going to give them. So you know about the Cord Equiner cards, I'm sure, available on the MACP website in over 30 languages now. And shortly, as a consequence of the international framework that Chris alluded to earlier, we'll have a safety netting animation available that includes safety netting patients for Cord Equiner syndrome. But whatever you use in your local bespoke pathway, the information needs to be approved across all boundaries and agreed by your local regional spinal network. Next slide, please. So, working together, we can make such a difference. Good communication is the glue that's going to hold this pathway together. It needs to be timely and it needs to be robust. Once you have the patient in front of you and you suspect Cord Equiner syndrome, your communication with them continues. They tell us that these are very scary days, these are very scary times in their lives. By explaining what you think and what's going to happen next, they tell us this makes a very scary day much more copable with. We often talk about communication with patients, but what about with each other? So make sure along your pathway you have clear lines of communication. Who is responsible for what? Who are you going to ring next? What number are you going to ring? Is it an up-to-date telephone number? What information will they need next and in what format? Once you get this working really well, it can work really smoothly, but you need to keep that communication good. So this framework is a fantastic springboard for local discussion. This is a great opportunity to work together to get this right.
Thank you very much, Sue. Jim, have we got questions for Sue?
We have indeed. Sue, that's marvellous. You talked about capacity, and in these days with increasing pressure on emergency departments, can you imagine a time where the whole process of Cord Equiner diagnosis and subsequent management would bypass emergency departments entirely?
Yes, I can. I think the important thing is to make sure you've got the capacity in your service to not be a bottleneck. If you have that capacity, I think that is kind of a really good way to manage these patients more effectively, with the clinicians with the skills to manage these particular serious conditions. We've heard from Professor Horner yesterday about the situation in A&E. You know, they have lots of emergency conditions of all types. These Cord Equiner patients may be sat in the context of today with other people who may have conditions that they may contract something that is significant to other aspects of their health. They may be seen by a junior clinician who is just taking the next patient off the list. If we can get that capacity to work correctly with the clinicians who've got the skills, we can bypass A&E, but it's got to be agreed across all stakeholders and across all boundaries. If you can get that right, it's fabulous for the patient and it's fabulous for the clinician.
Magnificent, thank you.
Thanks, Sue. Okay, up next we've got Stephen Vogel. Stephen is the Vice Chancellor of the University College Osteopathy, and Stephen's going to talk to us about the importance of having pathways outside the NHS.
Just in case my boss is listening, the Vice Chancellor, I better say I'm a Deputy Vice Chancellor. Thanks very much for inviting me today. So I'm talking about, it's kind of ironic after what Sue's just said about not going to A&E. You know, for practitioners who aren't in the NHS, independent providers, we know for some fairly old research I was involved in from 2007 that, well, physiotherapists as well, but more so osteopaths and even more so chiropractors feel unconnected to the system. So the pathway for people outside the NHS, as with my picture on the very first slide, is, if we're lucky, it's a muddy disappearing track, or it might be a signpost, but it isn't going to be a formal pathway. So what can we do as practitioners? Well, first up, have a look at the National Low Back Pain Pathway, which is based on the NICE guidelines for low back pain and radicular pain. And then today's launch, a fantastic implementation and add-on to the guidance from NICE, be aware, read the CES framework, discuss it with friends, talk about it as part of your CPD. Next slide, please. So Jonathan kind of alluded to this a bit earlier, but one of the things we can do is to really do some scenario planning. Think about it. You know, what happens if tomorrow, what day is it, Friday tomorrow in your practice, someone pitches up? Are you equipped? So spend some time. This is a really, really rare condition, but a serious one. A little bit like some of the vascular pathologies of the neck that might present to musculoskeletal providers, care providers. So do some scenario planning and then critically review and reflect on that plan and think about it. You know, what didn't work? How familiar are you with the CES framework? Can you map your scenario plan to clear actions from the framework? And if there aren't any, I mean, that's great. Reflective. We know all the regulators talk about reflective care and reflective CPD. This is a really fantastic opportunity to reflect and to enhance your practice. Develop your contacts, knowledge of local services. You know, if you get on the UKSSB website, you'll see the Clinical National Back Pain Clinical Network. It's open to all, and a very reasonable 35 quid it is too. And then you can contact your local leads and people on the committee, and you can develop some knowledge of local pathways. Next slide, please. So some practical suggestions. We've talked already about identifying a buddy or a senior colleague. Remember that if in doubt, you know, you don't have to be waiting if it's a clear-cut case to discuss with a colleague. You can get on an act. Safety net, go and look at the resources. If you're not in the NHS and you haven't got an agreed spinal network leaflet, no, Google Sue Greenhalgh, you'll find it. If you do that and safety netting, you'll find it. But the MACP have got a great website with translations. I work in inner city London, in Brixton. People have loads of different languages and backgrounds. It's available in 30, I think. I was looking the other day, 30 different languages. Fantastic resource. I suppose at a minimum, you should be thinking about who your colleagues are in the NHS, local GP, and having the phone number, having the contact details for A&E is a minimum. Think about your documentation. The framework is very clear about what to document, which is really helpful, but also think about how you might refer someone forward. Maybe have a pro forma ready, which will help you in the heat of the moment. Is extraordinarily stressful. My 30 years of practice, I've sent 3 people up to A&E, none of whom had cauda equina, but each time I was worried and ill prepared. I'm more prepared now. So just think about following up. Do check the actions of patients and what happened after your referral, because you have got a duty of care. Having done the referral, that isn't it. That isn't the end of your role, unfortunately, you might think. So I think that's my last point. Next slide, just in case. Hey, I was right. Okay.
Thanks very much, Steve. Susie, Jim, have we got any questions for Steve?
Yeah, I do. You just touched on it there, maybe with your pro forma to send in, but Larry Quioman and someone else, sorry, I can't remember their name now, says one of the challenges is often when you send someone to A&E, they seem to get refused or they don't have a scan. What do you think you could put in your letter or pro forma to get your referral taken seriously?
Yeah, this is relates to getting questionnaires filled in as well. Salience leverage theory. What you need to do is really make the headlines salient and what the consequences are. So I'd say, you know, some obvious things you do with every referral is you document symptoms, examination results, your provisional diagnosis and some actions, including things like duration and frequency. I mean, Sue just mentioned, actually, if it's going up to A&E, you don't know, well, you don't know. It probably is likely the person that gets seen at A&E will have less MSK experience than you, probably. So you need to make that stuff really clear. Put in the date, time of your contact, the duration, the frequency, and the progression. I think it's really important as well that you pop in a little bit of leverage. I am following the new or the National Back Pain Pathway for cauda equina, the nationally agreed format. So you're putting a bit of leverage on there. And on top of that, it's not helpful. Don't put any of your professional jargon in that you found this, that, and the other. And in addition, they had a stiff neck or this, that, and the other. You know, it doesn't need any of the stuff that you might be interested in as a practitioner in your MSK world or the language that you use. You know, make it transparent, make it understandable to others, and make it clear that you're expecting some action. And importantly, follow up with the patient afterwards and make sure that they've taken it seriously as well. You know, they might, I forget who now, maybe it was Sue as well, saying that, and I think it was Sue, just said, you know, the patient might think that increasing numbness, actually it's feeling better, I can't feel the pain so much. No, I didn't worry, I didn't want to bother them. I didn't want to go up because I've heard about the infection rate at the moment. No, follow up, be really clear about your duty there. That's to inform the patient. Don't project your fears of making them scared. They have the right to know, to make an autonomous decision themselves based on good quality information. And it's your job to give it to them, not to project your fears and concerns. And you know, really make a note. If they're saying, no, I'm not going, I'm not worried, I've decided not to, that's also their autonomous decision, but only if they're clearly informed to make that decision. So you'd record that in your notes as well. Gave all the information, gave safety netting, patient declined attendance. You might seek permission to speak to their GP, say, could I contact your GP, let them know this has happened, would that be all right? Just to alert someone else, and follow up, follow up. Coercion's not allowed, persuasion is a bit. I'm done.
Thanks very much, Stephen. Thank you, Susie. Last but not least is the chair of our network. Dermot's going to bring everything together for us, and then we'll finish with some questions and answers. So over to you, Dermot.
Wow, how do we follow that? Some great speakers. I've got the task of trying to bring stuff together. Just to say, we've got lots of people online, but also lots of people on YouTube. It's been great so far. So my role is just to pull things together. The Cor Equina has been a thing that we've really been trying to sort out since we got involved with the National Back Pain and Pathway. It's so important that we get together and we work this out because there's so many barriers. Sue mentioned the silos, mentioned all the different independent providers. There is issues out there, but I think together, and we've got about 500 people in this room, or in my room at the minute, and hopefully don't have to clean up later, that we can make a difference. So what I'd like to do, next slide please, is talk a little bit about the actual framework itself. This framework is it's a platform. It's not the destination of the journey, it's just a start. The whole issue now is to try and embed this pathway locally. The only person who knows how to embed that is you. I'm going to steal Matt Lowe, who's a consultant physio's metaphor. You're going to be navigating some uncharted territory here, but it's only really you that know the local terrain. You should take that patient's point of view, be their guide at the side, involve them early on. Co-production is key in this, collaboration is key. You want to plan this ahead. We know that the occurrence rate of this is pretty low. For a frontline clinician, maybe 1 a year. Steve's had a few. I know we work in spinal clinics and intermediate clinics, so we're more likely to see more. But what I want you to picture, if you knew that sometime next year you're going to have a baby, you would probably plan for it. You would probably make sure you knew the route to get to the hospital. You would probably know where to park. You would probably know the clinicians involved. You would have built up a relationship so that when it came to that Friday afternoon that we've all sat down, you wouldn't be that random person phoning up A&E or the spinal specialist. You would be, Dermot, oh, I know him. Oh, yeah, he mentioned that this, oh, and he's following the framework. Oh, right, yeah, that's great. So the important thing here is this is a framework. This is just a beginning for you to start to develop these relationships. It's really, really important to do that work now because, as Sue mentioned, that the time to learn to sail is not in the middle of a storm. You want to know that you're proficient, you want to know what to do, you want to have that paperwork ready because you, in front of that patient, are their guide. You need to know that you're safe and comfortable. And that confidence that you will instill in, will be instilled in them. So they will have the confidence to know that this person knows what to do. So how do we do that? Our role, next slide please. Our role in the National Back Pain Clinical Network is to try and help you with that. We have professional leads which cover physio, osteopaths, chiros, nursing. We have national leads who can also help you in your areas. In England, each national back pain rep feeds into a local regional spinal network. The regional spinal networks, all the leads are there. This is just a map that I've pulled up from the UKSSB site. You just go on there, you put on where you live, and you find out who that person is. We are there to help you to try and develop these relationships, to develop that pathway that fits into your local terrain, because you're the person who knows how this is going to work. Now, if you've got a problem, and I'm sure you won't mind me saying this, Dave Cummins is the clinical reference group lead for NHS England. He just said, give him my email. That's fine. I'll try and sort it out. We know that all the UKSSB societies are really engaged in this. We want this to work. Next slide, please. So, as I said, this is a framework. This is you're standing on a platform. This is the start of a journey. It's now down to you as a clinician to embed this framework locally. Be collaborative. Co-production, and I know Chris and myself are involved in the NHS Change Challenge. And the thing that I've learned over the last few months of working with the Change Challenge is co-production is key. Ask the patients early doors. Lived experience is what it's all about. And I'm sure Sue will back me up on this, that the understanding of a patient is just unbelievably useful. Speak to your colleagues, speak to the secondary care providers, commissioners, everybody involved, emergency care. Do not work in a silo. Try and visualize yourself on the other side of that referral. What would I like to receive if I was that other clinician? What would make my life easier? As I said, it is the start of a journey. And I think, and I know we have the right people involved, and that we can make a difference for a condition that really changes lives. Remember that frameworks, pathways are just systems. It's people like you that can make the difference. People like you can save lives and change lives. Okay, next slide, please. Please help and join us in that. Come and join us, 35 quid, have to do a little bit of sales. Be part of the network. Let's see if we can work on this together. Last slide. Over to you, Michelle.
Thanks very much, Dermot. So I think we'll go to the panel question and answer session, if that's okay with you. We've got quite a lot of questions. If people have got questions, please can you make sure you put them on the questions section, not the chat section. The chat section, absolutely, you can talk to each other, but we're going to try and get through as many questions as we can, and if not, we'll find a way of answering your questions. So please make sure that your questions go on the question section. So over to you, Jim.
Okay, so we have a question from Jane Davies and a very similar one from Catherine Netherton. Thanks for your questions, which revolve around virtual assessments becoming the new norm. How does this impact on the framework, and how can you reliably assess perianal and genital sensation virtually?
Okay, Chris, you want to take that one?
Yeah, very happy to take that. Thank you. Yeah, it's a good question, and we're all working very differently and remotely. We had a similar question last night, and I think I had a fairly flippant answer that Matt Lowe chastised me for. But my response was, it's not very difficult, and I think it's yeah, we can ask patients to assess their own saddle sensation and do that in a professional way, the same way that we would do normally. I think the key to, if you're asking a patient to test their saddle sensation or perianal sensation, is to make sure they understand why you're asking them. It's about being absolutely crystal clear about the value of that examination, and you know, being absolutely clear that it's a safety issue, and then you give the patient the option to do it or not. And the reason it might be helpful is that it might help you, one, in firming up your clinical diagnosis around cord recliner, but it also might be useful in order for you to quantify the amount of sensory loss that patient might have. So it might be they have 70% normal sensation when they test, and it might be when they get to A&E or see somebody else it's 20%. So it might just be a marker, same as any other marker. But it's I think it's perfectly easy to do, but the key is to set the examination up as you would do normally if you've seen someone face to face.
Thanks, Chris. Susie?
Yeah, I've got some questions here, quite similar, from Eileve Brown and Darren Smith and Martin Weeks. Are there any nationally agreed training or competencies for performing saddle sensation testing? And is there a standardized way to test it?
Sue, as one of the people who helped me when I was learning, do you want to take that one?
So did you say me, Michelle? No? So there's been a change really in how we've moved forward with this. There are some recognised guidelines now that are working with the pelvic health teams, and I think Chris actually messaged earlier of some of the guidelines that are out there now that are more concrete than we used to work with. But certainly it's having some line of competency teaching. You need to be in a position where you feel comfortable to do the test, and in primary care it's definitely about sensation testing to light, touch and pinprick. And on the subjective history, you know that on the cards, the wiping a patient after toileting is a good indication of if there is anything that they've already established themselves. But look at your training locally in your own service, look at what's agreed locally, look at your situation with if you are a lone worker or if you can have a chaperone, because as we know, if you can't have a chaperone, that needs to be documented, and don't do the test. But I don't know if Chris wants to pick up on some of the guidelines that you talked about earlier, Chris.
Yeah, I just mentioned on the chat that the pelvic and obstetric and gynecological physiotherapy group, who formerly the Women's Health group, they have protocols for saddle sensation testing, and previously they had them for anal tone testing as well. So we've lifted their guidance locally and adapted slightly. But it's just about finding someone locally, as Sue says, who's trained and competent.
So our local testing was taught by an orthopaedic surgeon, and then we've trained our other staff. And it works.
Thank you very much, guys. Jim?
The big thing is not difficult to test. So people have a concern about doing these things, but they're really not hard tests to do. You already know how to test a dermatome.
Okay. I've got three largely similar questions from Steph Cliff, Kaya Nadison, and Susan Bocci. Apologies for any mispronunciation, but they all relate to what we should do for our scan negative suspicious patients. So people that we send off, they have a scan, the scan is negative, but they still have profound disturbance to their bladder. And what should we do for those people? I understand the answer will be broad, but maybe just a summary would cover the area.
Stephen, I think you touched on that a little bit. Did you want to take that one?
You broke up or you asked, Michelle, was that me?
Yeah.
Yeah, so I can pick that up. So from the clinical situation that you assessed, so the subjective and objective examination, depending on how worried you were about the patient, you might decide if these lumbar spine scan negative cases came back that you might need to scan higher. Is there anything higher up the spinal cord, or is there anything out into the pelvis? So if there's clear neurological deficit, for instance, significant symptoms, but a beautiful MRI scan, that clearly needs investigating further, or even is it upper motor neurons, you need to go higher. The other thing is that these patients have a problem. So you might kind of think, oh, great, it's not Cordray-Quiner syndrome, thank goodness for that. But although that's a relief, these people are still suffering. They've still got significant pain. They may still have bladder dysfunction. And I think we can learn a lot from working with our pelvic health team. We need to look at moving forwards with these patients because they're really struggling. They've got pain issues and they have socially difficult issues in relation to bladder function, bowel function, maybe sexual dysfunction. So we do have a duty to follow these patients up and look at, do we have a duty to investigate further within the role that we have, or do we need to refer on to others who are more specialists in the area these patients are struggling with?
Sorry, I was, but just to endorse what Sue just said, I think it's absolutely that. You have to think about your duty of care and then your scope of practice. It may well be anyway a referral extant to you outside of your skills. Or if you think you've got some skills, I kind of think with these serious type symptoms for your average kind of MSK practitioner, you're probably not in your comfort zone for exploring these further. And the investigations, it's going to be someone else. So actually, if you're in independent practice, you're not going to go, all right, then, okay, let's do some, start doing some increasing your activity and get you walking. You're probably not in that zone for these sorts of symptoms, are you?
I think it's important to also think about things like neurological conditions. And the neurologists are very good at ruling in and ruling out neurological conditions. And they would then consider someone to have a functional disorder if a lot of these things are excluded. But you don't want to box someone as having a functional disorder until everything else has actually been excluded as well. So it's about thinking, I agree with Steve completely, this is often then out with the scope of an MSK clinician. And the GPs are actually very good at this. So like involve the GP, the GPs are used to thinking on conditions that we don't necessarily consider. But definitely recognise when it's something that you're not knowledgeable about and be very keen to hand that on.
And we're talking about primary care here. We have to think about our spectrum biases. I always talk, when I talk to my friends in tertiary and secondary care and physio, and I talk to Elaine and Sue and particularly Kika up at Keele, she says, oh, in primary care, you miss everything. You don't see anything. And of course, it's because we don't see many of these folks at all. But we have to recognise that. These things are hugely rare for us, and we're not going to have the day-to-day competencies to make these calls and to make the right diagnostic investigations and to call it. So, of course, we have to move on to people with more competence than us.
Thank you. Susan?
Okay, I'm going to, again, combine a few questions here from Anatole, Damien Kimber and Joe Hutchings. If a patient is subjectively reporting symptoms of Cordray-Quiner, what benefit or addition does actually performing saddle sensation testing add? Why will it change your management, and therefore why should we consider doing it?
Chris, do you want to take that because you covered that a little?
Yeah, I think just in terms of saddle sensation testing, well, you should be taking this one, Michelle, really. Michelle's work and others has shown that saddle sensation is or can be an early indicator of Cordray-Quiner or impending Cordray-Quiner compression. So I think I'm going to bat it over to you, Michelle, just to say a bit more about that. But that's my answer. Why?
Yeah, that's fine. We did a retrospective review of 1,000 patients that attended our emergency department that were scanned for possible Cordray-Quiner syndrome. And one of the biggest predictors we found was either subjective or objective reduced perianal sensation. So not just those that were tested, but patients reporting reduced sensation, i.e. when they wipe themselves, clean themselves, that type of thing. It wasn't statistically significant, but it was a highly predictive indicator of caudal equina syndrome on MR scanning. So,
yeah, can I just add to that the really good question, it wouldn't change your management, but with the onward referral, it would add extra information to that onward referral. So if the sensation was normal, but the subjective history it was concerning of caudal equina syndrome, you wouldn't stop referring on because the saddle sensation was normal, you would still refer on. But the saddle sensation would be extra information to add in that onward referral to give to the next person who is taking the part of the pathway.
I think it also demonstrates that you're a competent clinician as well. So, you know, if you send a patient in with a really clear story and demonstrate all the things that you've done and the things that you've found, the chance of that referral being accepted is much, much higher than if you give a really vague story. You know, so having all of these things means that, and it's part of how you build a relationship with the people that you're referring on to as well. Like they'll recognize whether you're a good referrer or someone that really doesn't know what they're doing. So it's partly about that. But the most important thing is it's actually a really useful sign. It's got more clinical utility than the other signs and symptoms that we have. And therefore it's an important thing to test.
It's really about getting that salience. And I like what you're saying there, Elaine, about credibility as well. You want that referral to be credible with salient information, even if you're not dealing with it often because it's so rare in primary care, but you're demonstrating that you understand the salient points, which adds credibility to the referral, and then your referral gets taken more seriously. And that's what you want.
thanks everyone. Jim, have you got another question?
Okay, so again, there's two people with broadly similar questions, Dawn Waits and Pete DeFada. Thanks ever so much for these questions. These are questions that I find very interesting. And does the panel think that if we did more of our scanning in weight bearing, our pickup rate or our diagnostic rate of identifying caudal equina would change? So would weight bearing scans change the pickup rate of CES?
Any volunteers? Elaine?
Firstly, you've got to remember that caudal equina syndrome is a clinical diagnosis. So the scan is really a second part to the story. And the scan is really about, is this something that we're going to operate on today or tonight as an emergency? And what the surgeons need is just a normal scan. Getting an upright scan is something that's not going to be practical in your normal A&E department or your spinal service. And we don't really know what the literature is saying about that, but I can't see hospitals are going to put in upright scanners for the small number of caudal equina cases that are scanned per day.
This is one of the problems of investigating rare conditions as well. Those folks who've got upright scanners like the AECC down in Bournemouth, you know, getting the numbers down to do the prospective study, to do a diagnostic utility test, upright scan versus horizontal scan. You know, I can't imagine that getting done. I mean, it's a reasonable question to pose the hypothesis, isn't it? The weight bearing, you might have some change in extrusion possibly, but you know, I can't see that being done.
Thank you very much, everyone. Susie?
Yeah, I've got a question here, similar ones from Lydia Catan and Roman Stachira. I apologise if I haven't pronounced your name correctly, about the usefulness of bladder scans. So they know that they can, in their experience, they used a lot in A&E plus or minus a PR to rule out caudal equina. So what's the panel's view on the usefulness of a bladder scan?
I think Michelle's the girl for this.
So the team in Nottingham use a bladder scan frequently, and they use 200 mils as a cutoff. And they find that if you have less than 200 mils, then potentially they don't scan those people. Now, we know from the work that Todd did looking at the incomplete and suspected and complete Cauda-Equina syndrome and those in retention, we want to catch the patients before they go into retention, because we know that the surgical outcome is better if we get the patients earlier. Once they've gone into retention, we're talking about those white flags of surrender that Chris talked about earlier. So absolutely a bladder scan can be useful. We found that on our research that the Cauda-Equina positive patients often had something in their bladder. They weren't fully empty in their bladders, but we didn't have a cutoff that was diagnostic of Cauda-Equina syndrome. And we had the biggest numbers. We've got bigger numbers in our study than they have in Nottingham, but we couldn't say anything for certain. I think the surgeons use it sometimes because they may have a Cauda-Equina and a tumour on their books. And who do they take to theatre first? Is the Cauda-Equina in retention? Do they have to release them because to try and protect that bladder? Or can they take the tumour, the MSCC that they've got? They're weighing up slightly different things. And sometimes they use the bladder scan to help them with those decisions as well. So absolutely, it's a useful tool. But I think in primary care, if you don't have access to it, it shouldn't be a deal breaker.
I think I'd say that there's a the evidence, the Venkasartan paper said there's a correlation between more than 200 mils are post-voiding or the more than 400 pre-voiding in other studies, but it doesn't diagnose Cauda-Equina, the Cauda-Equina compression. The MRI will tell you that, and the MRI plus the clinical examination will tell you that they've got Cauda-Equina syndrome. So it's part of the picture, I think, and I think as you say, Michelle, we're looking to catch these people early rather than when they are in retention. So
Nottingham used the bladder scan really to try and rationalise over who they're going to do an emergency MRI on and who they're actually going to leave and do a scan the next day. So they use it to rationalise between an emergency and an urgent scan. But if you have good access to MRI like we do in Oxford, we tend to, people still get bladder scans done, but you're doing them more just as part of that objective record of what people are like pre-surgery. And it means that you've got that sort of medical legal evidence of what the objective assessment of the patient was before an operation. But we very much have a low threshold for scanning, and therefore the bladder scan is definitely not used as a tool to triage who has an MRI or not. We would always say, if you think someone's got Cauda-Equina syndrome, you do an MRI. But we've got good access. That isn't the case everywhere.
Jim?
Hi, there's a nice question here from Isabel Hutchinson. Thanks, Isabel. This is a good question. I think the answer is no, but I'm going to ask the panel because they know much more than I do. Have any biopsychosocial markers been identified which might predispose someone to present with CES? If so, might they be identified using a valid questionnaire?
Jonathan, you look like you're ready to answer that one.
Yes, so the short answer is no. It's quite likely there are some lifestyle factors which might predispose you to it, which might be considered psychosocial factors. But actually, CES as we've heard, is a clinical presentation, and screening for non-physical factors isn't going to be significant. It would be quite unsafe to actually come up with a questionnaire which might make us less worried about a patient. I think our antennae should always be twitching for this with every patient that presents.
Chris?
There's the Huritz-Auer paper. They looked at 276 patients, and they were looking at features of scan positive and scan negative patients. And so in the scan negative patients, there were a whole range of non-spinal issues that were associated with those patients, but they were very similar to some of the chronic pain presentations. So they looked at things like fibromyalgia, non-epileptic seizures, post-traumatic stress disorders, eating disorders, and those sorts of things that were associated. But I think it's not a massive study. It's not, you know, they haven't gone into any more depth than that, but just so there's an association. So I think I'd agree with, you know, with Jonathan, but I think there might be some emerging evidence around that. So it's just one to watch, I guess.
Okay, we've got some similar questions here, really good, from Stephen Wilson, Rob Cook and Michelle Dinmore. If you've sent a patient to A&E and they're discharged without an MRI scan and you're still really concerned that this person does have Cauda-Equina syndrome, what do you do then? Is it suitable just to refer them for urgent outpatients, or should you be doing something else?
Sue, do you want to take that one?
Yeah, well, I think in light of Professor Horner's comments yesterday, it's really important to think that we may be the clinicians who have more experience with these Cauda-Equina patients with a subjective and objective examination than possibly the clinician that is the seeing in A&E. Not always, but that might be the case. So it's important to look at it at a case-by-case situation, and it may be, if you're still concerned that you want to speak to somebody further along the pathway, maybe your local spinal team, which is what we would do in our situation. But there is a certain amount of issues where you need to consider that the system works, but you've got to listen to it on the case-by-case basis and consider how concerned were you about this patient, how strong were their symptoms, and if in any doubt, then ask further along the pathway. And this is where the communication along the pathway is important. Who would you contact at your local spinal team? So, for instance, I commonly contact Michelle.
Mm-hmm.
No, and I think, you know, we've also all in again community and primary settings, we've all had, not just with CES, we've all had serious pathology that, although we're not seeing loads of it and we haven't got that experience and spectrum that tertiary care and secondary care and persistent pain folks like Elaine and Sue and Kiko have got, we've all seen people that have bounced around and been referred up. I'm thinking my wife saw someone the other day with a DVT in her thigh and been 3 times, GP once, A&E twice, and in the end sent her up again with another letter. And then the vascular nurse emailed back, said, fantastic, what a great shout, you spotted this person. Because people do bounce around the system, we have to be persistent sometimes. We've got that authentic concern and care for the patient, and that's not going away. And we're thinking about them, follow it up, carry on, bang on the door again, you know.
It's also a great learning tool as well. So it's that thing about following through and, you know, what then happens to the patient. You know, look back to that case in a few months' time. So have a think about, we know that only about 16 to 20% of people will have confirmed Cauda-Equina syndrome, and that's of those that are scanned. You know, so it's quite often the case that they're not going to have it and they will be sent away from any first thing to make sure we're not missing anything that's really important. But at the end of the day, it's good to have an audit of these things. Like if you've sent, you know, 50 patients up to the A&E department and they've all been sent back again, then you've got to think, well, I wonder why I'm sending them. What do I need to change in my own practice? But sometimes the threshold in A&E can also be difficult. So we were hearing that last night as well from Dan Horder in terms of how they have to balance risk. And, you know, you need to then involve your regional spinal network or your spinal leads to look at how the pathway can be improved. And the framework's a great way of opening those discussions.
Thinking about what Sue said about clinician care, you know, and I thought Elaine's point is great. If you're, you know, getting 50 bounce back, you might think again. But equally, you've got to be ready as well to feel a bit of a twit. You know, if they bounce back and nothing there, and then you fret again, GP, oh no, it's nothing. They've been seeing A&E, they're all right. And the patient is being kind of, thanks so much for your concern, but you were wrong. That doesn't feel great, you know. So you have to be robust about that. And that's where that buddying thing comes in, and getting peer support is so important. Maybe the spinal network and you know, contact experienced colleagues to talk it through and look at options, and decision making is so important.
What about spending a bit of time in a spinal unit? You know, what about spending a bit of time in A&E for experience? It's thinking creatively about, okay, I'm identifying that I've sent quite a few people to A&E or to the emergency service. They turn out not to have cauda equina syndrome. How can I professionally develop with that? But there will also be cases where they've been missed as well. So it's really important that those are reported, and they can get reported through the regional spinal networks as delayed cases or missed cases that you had concern about, you sent them to the emergency service, and at the end of the day, there was nothing really happened at the time you sent them, and then they go on to develop something much more concerning. It's important that they're reported.
It's not only important, but it's now a regulatory expectation with the duty of candour that applies to all of us now. It also includes identifying where things go wrong in terms of systems and pathways and others. So it's not just good learning.
And I want to just emphasise that quite often the ones where people really have a bit of a concern about them and they're then sent away from the emergency service, they can quite often turn out to have pathology higher in the spine. So we've seen some quite nasty spinal tumours that present like a cauda equina syndrome, but they've actually got some horrible thing in their thoracic spine.
I think it's worth mentioning as well that Professor Horner did say yesterday that RChem would be really keen for us as the experts to develop pathways away from the emergency department, because that, you know, they may have an RTC come in, they could have a sub-ARAC, they could, you know, everything's an emergency there. And Sue talked about that earlier. So we're at 9:30 now, which was the log off time originally agreed. We've got quite a lot of questions still to answer. So the panel are keen to keep going. So we're gonna keep going for about 15 more minutes, if that's okay. And what we're gonna try and do is any questions we don't get answered, we will try our hardest to cover and get answers back to you. How we're gonna do that, we've not quite worked out, but we will figure out somehow. So over to you, Jim.
Okay, so the next two questions are sort of about safety netting patients, and they're from Martin Brewer, and then there's a follow-up from Susan Bockey, who I think is the first person to get two questions asked tonight. Martin asks, do you feel you should supply all patients with lower back pain without radicular symptoms a CES card, even if there's no CES features? And follow up from Susie is that, from Susan, apologies, is she sort of understands that safety netting patients can induce fear, and this, she worries that this fear might be unwarranted.
I think as the person who wrote the cards, Sue.
Yeah, shall I pick some of that up? So, so we wouldn't suggest that every back pain patient is given the safety netting card. But those who are progressing, progressing radicular pain, especially if it's moving to bilateral leg pain, it's really important to safety net the patient, because they are the ones that could be at risk. It's important that they understand the context of this, that it is in rare situations, but it's important that they know. And what patients tell us is that they're worried about the situation. So tell us what to be worried about so that we can focus our concentration appropriately. In the context of severe pain, they can miss symptoms of cauda equina syndrome, but it's the pain that they're worried about. But they can kind of miss some saddle numbness, they can miss that they've got hesitancy of bladder function. So it's those that you clinically reason. It's not a black and white answer, that there isn't a black and white answer, but it's those who are beginning to progress that could continue to have a central compression, but I wouldn't give them to everybody.
Can I just comment? I'd agree with, obviously, with everything Sue said, but I'd also say that the safety netting is really helpful for patients' relatives and family. Having done a bit of work with one lady in particular and her family and their experience, you know, the experience of cauda equina was not just for Janine, the patient, it was for her whole family. And all of them said, yeah, if only we'd have known, we wouldn't have been scared. We'd have known what to look out for. We would have known what to do. You know, when we saw that, and we would have known the time frame. So that family had carried this guilt for 13, 14 years. That was the husband and the daughter and the patient as well. So I think the safety netting is as much for the patient as for those carers and relatives as well. So I think it's just worth remembering that.
Thank you.
I just wanted to add a slightly different nuance to it. In the formal safety netting and giving good quality information when you've got concerns is different to when you're asking a case history. I routinely ask about sensation and bladder function, bowel function. Now, I like to try and work with the patient, so I don't do that out of the blue. I normally say, I'm going to ask you a couple of questions about this because of. And so I kind of frame it contextually, which isn't the same as formal safety netting, but it's giving a bit of a context for those questions and explanation. And if you're saying, there are a couple of really rare things, and pain both your legs and numbness and round your perineum, we wouldn't use that language, but if your bladder works, I'm asking, because, people like to consent to know, why is he asking me I've got a bad back? What's he asking about my bits for? What's that about? So, part of that process of consent is also giving information at the same time, which is not the same as Sue's very brilliant work on safety netting. But it's contextualizing, isn't it? It's giving that bit of information. Oh yes, the chiropractic hospital did ask me about that. What's that about? I haven't forgot that funny feeling down there now. And I can't go, yeah, what is that about? So, there's something there as well, isn't there?
If I can just add that we've got to remember that with the cards, they were developed by Cordray-Quiner patients for those at risk of Cordray-Quiner syndrome, because they said these are the things that they missed and these were the things that they didn't know about. When we originally developed them, I did have a few hot sweats thinking, oh, are we going to get a tsunami going to A&E of the worried well? But over the years, that hasn't been the case, and we get to hear time and time again of patients presenting appropriately and, understanding what to look out for. So they are useful.
Guys,
I have to say that I work in a service that receive the people who are the worried well. So they have been safety netted, and perhaps it wasn't always in the best way. It's created anxiety. We see them as repeat attenders to A&E where they develop symptoms. We have a complex pain disability group, and when they understand about what these symptoms are, sometimes they develop them. It's really difficult. And I think it's about understanding the person that you're giving that information to and how they're going to react to it. And I fear that quite often these things are just pushed to patients. They're not supported with a good explanation. And the reason the clinician's doing that and putting it in the letter is really for medical legal sort of defensive medicine. And that's not good medicine. So anything you do with safety netting, it's got to be done in a very mindful way from the point of view that this is good for that person.
And last few questions, Susie?
Okay, well, hopefully this could be a brief answer. I don't know. This is a question from Paul Regan. Is there a definition or approximate time frame for urgent versus emergency MRI scan?
Dermot, do you want to take that?
Dermot's muted.
Elaine, do you want to answer? He's here.
Every centre is going to have different definitions. The emergency scan will always be the same. The emergency scan is the next scan that is available. The urgent scan will differ in where you are. But when it comes to Cordray-Quiner syndrome, but they're not thinking that it's something that, it might be someone who's early and they've decided that they've got 4 tumours to do and, a washout or something else that's really important. It might be they choose to leave that person to the next morning, and they would therefore, if they're not going to operate overnight, they'll maybe scan first thing in the morning. But so urgent in Cordray-Quiner syndrome is a bit different than urgent referrals that you might be making for another spinal condition.
That's but what about, because on our framework we talk about, do we think that they need to be referred for an emergency MRI, potentially going to ED if that's your pathway, whereas we have talked about other scenarios where maybe you would consider more an urgent MRI scan. So
the pathway doesn't talk about the MRI. The pathway is about urgent and emergency referral.
Right.
And I think that's really important. So this framework is about getting the person to the service that can do something about it. And again, that will differ with where you work. And it's what that service do in terms of, is it an emergency or an urgent MRI? But the framework is about whether it's an emergency or an urgent referral.
Yeah, I have to agree with Elaine there that it's kind of outside of our scope and outside of our control. We would hope, and I think what we've learned over the last year or so in developing relationships with all the different stakeholders and professionals, that we might be able to hone this down and get some more, a pathway that goes end to end from primary care all the way to spinal injury clinics. It is a case of this will take time, but as far as the framework goes, that's outside the remit at the moment. Once it goes to that front door of secondary care, then it's actually their decision.
And it's BAS that will actually develop the guidance on that, but we'll try and make sure that everything aligns.
Last question then, Jim, make it a good one.
Well, I'm going to fudge it then. There's a lovely comment from Larry Koyama, who says, sends his congratulations to you as panelists and people that have developed the framework, and he wants to know about the dissemination plans. So I think, thanks Larry, that's very kind, but it'll be on the UK SSB website. There is a question that's sort of perhaps more pertinent, which is Vicky Curry and also Tom Kelly asked broadly about the specifics of testing saddle sensations. So this is a theme throughout tonight. Is it light touch? Is it pinprick? Is it 2-point discrimination? How big's the area? What's a positive finding? So we're looking for some summation of the nuance of sensory testing around the saddle region.
Chris, you're nodding. Do you want to take that succinctly?
Yeah, light touch and pinprick, yes, and consider the saddle as a much broader area than you would think. Sue describes it as everything that touches the chair when you sit down. So it's a big area. So if you test all of that sensation, all of that area with light touch and pinprick, and you're looking for side-to-side differences, so you can grade that however you wish. But if you can kind of get the patient to estimate and grade it, then that would be helpful.
Brilliant, thanks.
Fantastic, thank you.
I can't, as an ignorant primary care clinician, I can't help but think it doesn't really matter. You start out wide and you work in. And when you've got deficit, you're concerned.
It's also easy to look at Dr. Google. There are many dermatome charts out there, and they all differ a bit about where the sacral nerves supply. But if you have a look at several of the charts, you'll get a fair idea of what the sacral nerves cover. We all know how to test the dermatome.
Yeah.
Brilliant. I think, thank you everyone for joining us. Thank you very much for the panel, for all your time and efforts, and for all of you out there. And I'm going to hand over to Dermot, our chair, to just sum everything up and close, if that's okay.
Dermot, you're on mute.
Well, that was great. What I said was brilliant there, but that's okay. I hope everybody's enjoyed the evening. I found it really, really useful. I think every time I sit in a webinar or I take part, I always learn more. And I think that's great to see. We do have a group of people who are involved here, and I think we can push this forward. As I said, this is a platform for you as clinicians to go out there locally, to develop your skills, to develop the paperwork, but to actually become more confident in managing this condition, so that you can be a better clinician for your patients. Just to wrap up the feedback on the webinar, we'd like everybody to give us some information on tonight's session. All the agencies involved here would like that feedback. The National Back Pain Clinical Network would like to run more events, and the more we know, the better. The actual framework itself is going to be placed on the UKSSB website. It's open for comments until Friday the 14th of August. From last night's session, we received quite a few comments already. Please send them in. We want to know what your local area is like. We want to know what the terrain like is locally for you, so we can try and help that. Just let us know. It mightn't be a clinical question. It might be a what do I do if, and where can I go? Just ask. Let's see how we can help each other. So just to say as well, the videos of tonight's session and last night's session will be uploaded onto the site. So as you saw tonight, quite a few of us mentioned about last night's session, which was more secondary care focused. If you want to watch that, it's well worth watching. So it comes to me to thank you all, thank all the people involved. So our own society, the network, the APPN, the Institute of Osteopathy, the UKSSB, MSCP, and the chiropractors who's of Royal Society, I can't see at the moment. I'd like to thank you all, but I'd also like to thank Bas and Henry in the background there from BOA, which is helping us. So good night to you all. Thanks a million, and hope to see you again soon. Bye-bye.